mean, that's very, very interesting because it you're kind of saying Parkinson's disease is not like one disease with the exact same thing. It's like the symptoms are the same, but the underlying causes
Yeah,
are potentially very different each time,
yeah.
and therefore the treatment's very different each time.
Yeah. I think that's so. Actually, just to give a little more, actually, with Parkinson's disease, although I've mentioned, yeah, it's a movement disorder. No two cases are the same. It's incredibly heterogeneous. So very different cases all throughout. It always has to have movement disorders, but I could list off about another 10 symptoms that go along with it. I will even list them off now. So, autonomic dysfunction, whether that's problems with your urinary tract or constipation. Autonomic dysfunction can also be problems with your sleep. So, you can get something called RBD, which is rapid eye movement behavioral disorder. And basically, that's when you dream, you don't have something stopping you from almost living out your dreams. So, people are all out, they're moving their hands, they're walking, they're almost like sleepwalking. Then you can also have depression, anxiety, psychosis. There is so many extra um, symptoms that a lot of people don't realize. Cognitive decline is one that I'm currently looking at. It's so multifaceted, and that could be the fact that and that's another part of my research is where I'm trying to group certain people with certain symptoms a little bit better to understand like the biology behind that a bit better, because there's a big people start well, it's been going on for a while now. People think, can you just look at Parkinson's disease because no two cases are the same? We probably have to look a little bit better and look at something called personalized medicine a little bit more. That's where, if no two cases are the same, we have to take this person, their symptoms, and treat them specifically, uh, yeah, to help them.
How do you, I think when it comes to something like cancer, everyone is very aware of it. Um, Anyway, it's one of those things where the more people are aware of it, um, you kind of get, for example, in people that are perhaps slightly more predisposed to sort of anxiety, etc., or have anxiety conditions, because there's a lot of awareness of cancer, and there's a sort of awareness and knowledge that, oh, if this is hurting, it must be cancer. It's that classic
Mm-hmm.
thing of you Google your symptoms and it tells you have cancer. What is there a fear that, you talk about cancer, there's cures coming for that, and so the next second biggest one is then Parkinson's disease. Then how do you avoid a moral panic where if someone essentially has a UTI, a urinary tract infection, how do you stop them from assuming the worst and that they've got Parkinson's? Like, is that going to happen?
Yeah, no, that's a good question. So things like UTI and constipation are just something that a minority have, or not that many people have, and it wouldn't be the only symptom. It would be like an extra. So we've got something what we call prodromal Parkinson's disease. That means that it's before you can see the movement changes. So it's called prodromal. But if you were to scan these people using something called a DAT scan, you could see that there was starting to be some loss of dopamine, but it hadn't yet affected their movement. And there's probably the most common risk factor and the most common symptom that I've just briefly discussed was the rapid eye movement behavioral disorder. We'll call it RBD, which is that if you have that, then it doesn't mean you're going to get Parkinson's disease, but it's common enough that you want to get yourself to the doctors and monitor it. There's been a couple of people that I've scanned recently who started with RBD and they then went on to get Parkinson's disease. So
And so I guess what's the symptom then that people, is it people waking up one day and suddenly they've got tremors and then they get diagnosed? Or is it, you wake up one day and you've got like, a bit of a twitchy eye and then it
yeah.
takes 6 months before it's like, oh no, and your doctor dismisses you the first time because it's like, oh, you probably just slept on it funny.
Yeah.
Um,
I mean, I'm not a clinician, but I think from what I can tell, well, when it is, but it's insidious. It actually the tremor isn't always straight away. It's slow. It's very slow, and then it's just been like 6 months or a year, and they're like that tremor's not gone away, and then it's slowly getting worse and worse. There was a woman who came in who said like she hadn't really noticed anything, but she was painting, and when she painted, she noticed that there was the tremor there when she was trying to paint. And she's like, that wasn't there before. And it was there for about 6 months. So that's what, it was doing everyday activities where I think people start to realize. And it's not always you that realizes because it's insidious and it's happening slowly, you just think it's the norm. It's actually usually relatives that start to notice some of the movement issues. Yeah, so that's probably, but the RBD, if you were to get things at RBD, and sometimes something called anosmia, which means you lose your sense of smell a little bit. There's also another one that kind of is a little bit of a prodromal one, but that can also be quite common for other reasons, such as COVID-19.
Great names, anosmia for the nose.
Anosmia just can't smell.
I suppose, it goes into an entirely different topic and probably a whole other podcast episode, but then I imagine with a loneliness epidemic that we are seeing, you're going to get less cases being known because, like you say, if people rely on others to point it out, you might just end up with people not even realizing. And I think the other thing as well then, so when you go to the doctors and you're like, right, I've got this tremor, do you have to go for an MRI? Can they do a blood test? Like, how do you get diagnosed?
Yeah, that's a great question. So it's actually a clinical diagnosis. So that means the clinician will diagnose it, and they have some clinicians who I know who are just so, they've seen so many cases, it's almost like they just go up, ask a couple of questions, and they, ask them to do a couple of tasks, and they just know that, like, you do have Parkinson's disease. And but then there's something called the Unified Parkinson's Disease Rating Scale, UPDRS, that can tell you a little bit more about those symptoms and the extent of them. But saying that, Parkinson's disease is not the only movement disorder. So there's some other rarer ones. They're called Parkinson's plus syndromes. An example of that is something called PSP, or multi-systems atrophy, that look very similar to Parkinson's disease. They're usually a lot more aggressive. So if you have one of those, the survival rate or the quality of life isn't as great and survival rate isn't as long, but they can prevent it very similar. And if they think that they might have one of those diseases, absolutely, that's when you'd use something called, you'd probably want something called a DAT scan that can show you that there is one-sided loss of the dopamine neurons, which is what Parkinson's disease is, how you can identify Parkinson's disease a little bit better, or if you're unsure. But a big problem is these DAT scans are expensive. They're very expensive, so they won't always put people in for a scan because it's just too expensive. And if it can be diagnosed with a clinician, then that's what they'll do.